Morning, everybody, those who are in the room and online. Today, we're very lucky to have Gideon and Titus give us a talk on a ridiculously important topic. Gideon is the newest qualified pulmonologist in our department, and we're obviously super excited to have him. So I think it's going to be a very important discussion today about a specific topic as pulmonologists that we find incredibly frustrating to manage. So I'm looking forward to some insight.
Thank you, Erika, for the introduction, and good morning to everyone. Welcome. So as Erika mentioned, this is a very important topic. It's something that we experience basically on a daily basis in clinical practice. And there hasn't really been a lot of research into the topic, surprisingly. I mean, the last update on this topic was in 2010 from the British Thoracic Society. And it's only of late that more and more publications have been coming through to the extent that recently in 2023, the British Thoracic Society released another updated guideline. Change my slides. All right. So just looking back at pleural space infections, this has been recognized as a disease since at least 3000 BC. And it was first described by an Egyptian physician by the name of Imhotep. But it was only till about 2000 years ago when the Greek physician Hippocrates actually attempted drainage of the pleural cavity to treat this infection. So it's been around for a very, very long time. Despite all our early attempts in treating pleural infection or empyema, the mortality rate still remained very high. And in the early 1900s, mortality rate was conservatively reported between 20 and 30%, which is quite high. Unfortunately, if you look at the trend of pleural infections, it doesn't look very promising. Data from first world countries is showing that the incidence of this disease entity is still increasing. You look at the top graph in gray, that's from Denmark. They sitting with an incidence rate of 11.8 per 100,000 population. Unfortunately, the data doesn't represent any statistics from sub-Saharan Africa or Africa, because we've been lagging behind in terms of publications on pleural infection. Hopefully that would change in the near future. So why is there increase in the incidence? It's probably various factors that's contributing. One of it is that there's an aging population. Patients are living longer with chronic comorbidities such as diabetes. We're using immunosuppressive agents more liberally. There's also been a natural evolution of our bacterial pathogens. And then also our imaging has improved. So we've got access to advanced imaging like CT scans and ultrasounds, which makes it easier for us to actually pick up these pleural space infections. Unfortunately, similar to the 1900s, patient outcomes hasn't really improved despite all our recent advances. Looking at mortality, 30-day mortality and 3-month mortality, it's still sitting at about 10%. And the 1-year mortality is sitting about 20%, and it's going up to 35% in our elderly and immunocompromised patients. So certainly newer treatment strategies and more research around this topic is urgently needed. In terms of implications and costs, we all know that once you admit a patient with pleural infection or empyema, they tend to be in hospital for a very long time. From first world literature, the median length of hospital stay is about 14 to 19 days. And it's associated with significant healthcare resource utilization because, as you can imagine, there's a potential requirement for prolonged antibiotics. Many of the patients need chest tube drainage. Some would need intrapleural therapy. And in the more advanced cases, surgery would be the only option for these patients. It's also in terms of cost, one admission for pleural infection can cost up to 400,000 Rand. So quite a significant impact on our healthcare resources. So, like I said, there's very few large multi-center randomized controlled trials around this topic. Of late, there's been several single-center studies that looked at pleural infection, and a lot of new things has come to light that's starting to change our understanding about this disease entity. Some of the recent findings showed that in about 30% of patients with a primary pleural infection, there's actually no radiological evidence of underlying pneumonia. What they found in these patients is that the microbial profile is similar to that of the oral cavity. And there's now a suggestion that perhaps there's a alternative mechanism in terms of hematogenous spread of these organisms into the pleural cavity. So a lot of research is going into that theory. And then also, obviously, there's been a lot of advances in terms of surgical management of pleural infections, where we've become less and less invasive with our surgical strategies. Those are a few highlights. The rest will go into a bit more detail throughout the course of the talk. So just as the definition of pleural infection, according to the ERS, it's a collection in the pleural space in a patient with infective symptoms, and the patient should have a pH. The fluid pH should be less than 7.2. The glucose should be less than 2.2. Obviously, in the context of a normal serum blood glucose, or the pleural correction should be culture positive, or there should be frank pus when draining the fluid. It goes through different stages, and I think the understanding of these stages are important because it impacts our management. The first phase would be the exudative phase. This is when there's the initial pleural injury. You'll get inflammation of the pleura. That's followed by neutrophil chemotaxis and your increase in your vascular and pleural permeability, and that leads to the accumulation of fluid in the pleural space. Usually at this stage, the fluid is still what they call simple. The pH is still above 7.2. The glucose is high. The LDH is low, and generally you don't culture any organisms at this stage. But if left untreated, you'll then go into your fibropurulent phase, and this is where you activate your coagulation cascade, and you also get increase in pleural deposition, leading to the complicated parapneumonic effusions. And then at this stage, the patient starts forming fibrinous septations and loculations, and the pH now drops to below 7.2, and it's usually during this phase that we start culturing our organisms. And then if this is left untreated, you then go into your organizing phase, and this is when the patient develops frank pus, and if left untreated, they'll then develop a pleural peel. All right, so for patients with simple pleural effusions, look, this is not a hard and fast rule, but it's a little bit of a clinical clue. If the pleural effusion is still in the simple phase, the fluid tends to move more freely, and you still tend to get the curvilinear line, or the meniscus sign as we know it. As the fluid becomes more complicated, you get what we call the D-shaping or D-shape opacification, or the obtuse angle with the pleura. And once you see that formation, then you should be alerted that you're probably dealing with a more complex collection. You know, the sensitivity and specificity of chest X-ray is poor, but this is a clue to the degree, or to the extent of the infection, or the stage of the infection rather. More and more now in literature, and in you'll see in the pulmonology department as well, we leaning towards lung ultrasound. It's a very, very useful tool. In fact, the guidelines now suggest that you don't even attempt a diagnostic pleural tap without doing a lung ultrasound first. There's been many stories where if people go blindly, they'll actually perforate abdominal contents and all of that. So it is advocated to use lung ultrasound prior to doing any pleural procedure. And ultrasounds are freely available even in the ED. So these are the different presentations of how the fluid can present. Generally, when it's a simple effusion, you'll get an anechoic fluid, and that would be picture A. Generally, transudates tend to look like that, but however, about 20% of exudative effusions can have a similar appearance. So if you see that image on ultrasound, it doesn't mean that you don't need to do further diagnostic workup. You still need to investigate the fluid, especially if it's a large collection. And then obviously, as you go through your fibropellurin phase and your organizing phase, the fluid appears more complex on ultrasound imaging. All right. We know that the definition states that the pH should be less than 7.2. Just for us to keep in mind that there are many factors that can actually influence the pH on the fluid analysis. The one thing that catches us is the delay in processing of the pleural fluid. So it is suggested that you process your fluid within 4 hours. Otherwise, you'll get a falsely elevated pH. So that's something that we need to keep in mind. Also, a lot of times when we do the pleural tap, we do use local anesthesia, and just to note that the lignocaine that we tend to use can actually falsely lower your pH. So one has to keep that in mind. And then also, if you look at the loculated effusion, this is picture C. Every pocket can actually have a different pH. So sometimes if you tap, you can be falsely reassured because the pocket that you actually tap from, the pH is higher than 7.2. So just to keep that in mind as well. And then also, just importantly, we need to use a sterile technique because it's common that we get back skin commensals on our cultures, and that can obviously alter our treatment strategy. All right, so just in terms of common organisms, looking at community-acquired pleural infection, by far the gram-positive aerobes are still the most common, and that will include your strep viridans, your pneumococcus, and then Staphylococcus aureus is also still quite important. It's a little bit different when you look at hospital-acquired pleural infection, where Staph aureus seems to be the predominant microorganism causing infection. All right, so now we're going to go into a few of the updates from the ERS. So generally, the yield on pleural fluid is quite poor. It's about if you're just using blood cultures, you get about 17% positivity rate in the culture. So now it's been advocated that we actually tap the fluid and put it into the blood culture bottle. And it's been shown that we can increase our microbiological yield by about 20% if we put fluid directly into the blood culture bottle. So I know a lot of times we tend to send the fluid away in the sputum bottles, the blue top, but they are advocating now that we actually use blood culture bottles, and this will increase our microbiological yield, which is very important. There was a pilot study called the audio study that looked at 10 patients where they actually did pleural biopsy on patients with pleural infection. And what they found was that there was a 2.5 to 4.5 fold increase in your yield, microbiological yield. And they hypothesized that the organisms would rather infiltrate the tissue than proliferate in your hypoxic hypocellular pleural fluid. And just recently, actually, in the renal unit, we did a pleural biopsy on a patient with an unexplained exudative pleural effusion, and the tissue actually grew fungus. So there is definitely some truth to this, but however, this was a small study, and it's not yet advocated internationally for us to do pleural biopsies on patients with pleural infection. But something to keep in mind, and something we'll probably see more in the literature in the future. All right, so we have to keep in mind that because of the poor yield on the microbiology, we cannot use this as a definitive or as a be-all end-all in terms of making the diagnosis of pleural infection. So this is a very important slide from the ERS because this guides us as to who gets the chest strain. All right, so if you suspect a pleural infection, And the fluid is not frankly purulent, so it's not pus draining. They advocate that you immediately do the pH. If the pH is below 7.2, the chances are you have pleural infection, and they advocate that you put in the chest drain immediately. If the pH is between 7.21 and 7.39, this is a bit of a gray area. So what ERS is advocating now is that we check the fluid LDH. If the fluid LDH is above 900, and the patient has one of the following, which is a large pleural volume, or the glucose is below 4, or there's pleural contrast enhancement on the CT scan if you have a CT scan, or if you've done an ultrasound and there's septations on the ultrasound, they do advocate that we put in a chest drain for these patients, because the chances are that they have pleural infection. All right. If the LDH is below 900 and the pH is above 7.2, there's no indication for immediate intercostal drainage. If the pH is above 7.4, there's a very low risk that this is actually a pleural infection. There's no immediate indication for intercostal chest drain. So you'd monitor this patient clinically and check the response to treatment. So duration of antibiotics, not a lot of data, unfortunately, and every center I've worked in so far has different ideas around this because of the lack of data. I know when I was training at Tygerberg, they told us to give antibiotics until the patient was not draining anymore. When I was at Barra, and when here the practice is different, but the ERS now advocates at least 3 weeks of antibiotics for this patient. I think that is the accepted time period. In the context of a patient that's improving clinically and the inflammatory markers are on a downward trend, 3 weeks should be sufficient. There was a trial looking at a shorter course of antibiotics, as a 2-week versus a 3-week antibiotic strategy. And this trial was quite promising because the patients actually did well in terms of reaching clinical stability, and they were successfully, the pleural fluid was successfully drained, but it was a very small cohort of about 25 patients. And so even though the results looks promising, we do need larger trials to confirm this. So the feeling at the moment from the ERS and international bodies is at least 3 weeks of antibiotics. All right, this you're probably going to see more and more in the literature. This is it's a prognostic risk model that's been, I think it's published about 2 years ago, the RAPID score. And this is the first prognostic risk model that specifically looks at pleural infection, and it gives you, it predicts 3 months mortality. And it's been validated in many countries already. And basically what they use is 5 clinical parameters. If you look in the far right, they look at your renal function, patient's age, the purulence of the fluid, the source of infection, dietary factors, and the score will be allocated for each of these. You then fall into either a low risk, medium risk, or high risk. If you fall into the low risk category, your 30-day mortality is about 1.5%. If you fall into the medium risk, 30-day mortality is about 20%. And if you fall into the high risk category, your 30-day mortality is actually up to 50%. It's very high. The problem with the RAPID score, even though it's been validated, we don't really know where in the treatment algorithm this fits. So we've got this tool that tells us about mortality, but we certainly need more research to tell us where exactly in the treatment algorithm the score fits in. Some ideas that came forth is that perhaps if your RAPID score is higher, that we should be more aggressive in treating. And these patients should all go to surgical management immediately, versus a lower RAPID score could be treated perhaps more conservatively. Although these theories still have to be tested in bigger randomized controlled trials. But this is something that you're going to see a lot in the pleural literature that going forward. In terms of the intercostal drain, so generally a small bore drain would be less than 14 French, large bore drain above 18 French. And traditionally we used to go for the large bore drains because obviously we were worried about the viscosity of the fluid that's draining and the drain being blocked. However, there's been one large study called the MIST trial, that actually looked at intercostal drain, and the question asked was, does the size of the drain actually affect the outcome of the patient? And what they found was that it actually doesn't. There was no difference in primary or secondary outcomes, which was death, the need for thoracic surgery, the length of hospital stay, according to chest drain size. So and what they also found was that the larger bore chest drains were actually associated with more pain. So they actually advocate that we should be going for the smaller bore chest drains in patients with pleural infection. The one caveat, though, is that in the MIST-1 trial, the drains were flushed 3 times a day with 30 mL of saline. And I think that's without that, then obviously the smaller bore drain would become clogged up. There was another retrospective trial looking at 58 patients with intercostal drains. They were flushed with 20 mL of sterile saline every 6 hours. And of those 58 patients, only 1 drain actually clogged up. So we've used small bore pigtail drains for a couple of empahemas, and I must say it's a lot more comfortable for the patient, and they do get the job done. One just has to keep in mind that you do have to flush it quite regularly. All right, then this was a very big study that came out. This is the MIST-2 trial, and I just want to touch on this. I don't want to go into too much detail. But basically, in this trial, they hypothesized that when you look at pleural fluid, there's 2 things to consider. It's quite thick, and they attribute this to the uncoiled DNA that's liberated from dead leukocytes, and this creates a gel-like solution. And then the other thing to consider is that as you're going through the stages of pleural infection, the fluid starts getting fibrinous septations within the collection. So they hypothesize that if you give a DNase to mop up all the uncoiled DNA, which is liberated from the leukocytes, and if you give a lytic such as alteplase to break down the septations, that you'd actually be able to drain the pleural infection much more effectively. So what they did was they randomized patients who met the criteria for pleural infection. So they had to have a gram stain that was positive, or there had to be pus coming out of the drain, or the pH had to be less than 7.2. There was obviously a whole list of exclusion criteria, which I won't really touch on. And they were randomized into one of the 4 groups. So they either received the combination of alteplase and interpleural DNase, or they received alteplase placebo with DNase, or alteplase with DNase placebo, and then the last group just received placebo, alteplase, and DNase. And the primary outcome was to look at the radiographic improvement of the pleural collection at 6 days post treatment. So they used the computer software to actually measure the space that was occupied by the pleural collection. It was done on the initial X-ray, and then again at day 6 after treatment. And if you look at the table, there was quite a good equal distribution across all 4 groups. And what I really want to highlight is that what they found was that in the TPA DNase group, there was quite a significant change from the baseline in the hemothorax area occupied by the effusion. That's the only one with a significant p-value. They also found that there was decreased surgical referral for these patients, and the length of hospital stay in these patients were also reduced. In terms of adverse outcomes, see, the p-value was insignificant. There wasn't really a difference in adverse outcomes across the groups. However, just to note that in the TPA DNase group, there was 2 cases of interpleural hemorrhage and 1 case of hemoptysis. So just to keep that in mind, if your patient is a high bleeding risk, probably this is not the way to go. So the article concluded that if you actually combined interpleural TPA, such as alteplase, and if you give DNase therapy, it actually improves the drainage of pleural fluid in patients with pleural infection. It reduces the length of hospital stay, and it reduces the need for thoracic surgery. So this can be a useful option in patients in whom standard medical therapy has failed, and in patients in whom thoracic surgery is not really a treatment option. Medical thoracoscopy, very effective, especially in the early stages of pleural infection. But even in first world countries, places like the UK, they've documented that it's really not that feasible because you do need anesthetic expertise, and you do need full backing from cardiothoracics in case anything goes wrong while doing the procedure. So that is the issue with medical thoracoscopy. And then obviously surgery also has a role to play, especially in patients who failed medical therapy and patients who are in the organizing phase of empyema. So this is if you didn't remember anything from the talk, this is the slide actually I want you to remember, because this is the latest ERS treatment algorithm, and basically we're going to end off with the slide. So if you have a patient with a confirmed pleural infection, according to our definition that we've discussed earlier, the next step would be to calculate the rapid score. All right, because this risk stratifies the patient. They do then suggest that if your patient is clinically unstable, or there's profound pleural thickening, or there's a solid pleural collection, then you'll go down the right-hand side of the algorithm and you go straight for surgery. Okay. If the patient doesn't meet that criteria, they then suggest you put in a small bore chest drain, so 12 to 14 French intercostal drain. The patient must then be reevaluated within 48 hours. If there's a good clinical response, you then continue with your current management. But if there's a poor clinical response, in other words, there's a persistent pleural shadowing, or your inflammatory markers are static or worsening, they then suggest that you proceed to a thoracic CT scan. Once you have the CT scan, you'll have to decide if your patient is a surgical candidate or not. If the patient is a surgical candidate, they then advocate that you refer the patient for surgical intervention, which nowadays would be minimally invasive surgery, such as a VATS. If your patient is not a surgical candidate, they then advise that you consider interpleural treatment with TPA and DNase combination therapy. Failing that, you might have to do a more prolonged antibiotic therapy, or you might have to switch your empirical antibiotic therapy, or you can insert the indwelling pleural catheter. The indwelling pleural catheter allows the patient then to go home, and they can essentially drain the fluid at home, which is very, very useful. All right, so that is the current suggested treatment algorithm for pleural infection. There is a lot of work going on in the field, multiple studies going on. The one I'm keeping my eye out for is the pleural irrigation trial, because that's a trial that I think probably in our setting would be useful, where they actually irrigate the pleura 3 times a day with about 200 to 250 moles of saline. So we watching for this trial to see the outcome. Maybe it's something that we can implement in our setting where we have resource constraints. And then, yeah, just my last slide, please. I'm sure you've seen this circulating. We have a pulmonology CME coming up, and we encourage everyone to register and attend. And thank you for your attention. Okay.